very much for inviting me to talk today. I'm just going to do the nerve-wracking moment of sharing my screen. And I just wanted to start with this because I'm very aware that I'm here talking about a phenomenon that I personally haven't experienced, to a room where many of you will experience this on a day-to-day basis or have relatives who do. And I think within the rare disease space, and particularly with periodic paralysis, it's a place where this combination, if you like, of lived experience and learned expertise, where has real power when you work together to take things forward. And I'd like to start really by describing an aspect of that that I think was some really, really key work looking into this aspect of permanent weakness in periodic paralysis. So the first descriptions really of this were, I think initially even in 1897, there's a seminal paper that I can never find to download, but where the vacuoles and the features that can be seen on muscle biopsy was first described. But then for a long time, really, the focus was on the dramatic episodes of weakness that people experience and is the name of the condition. But I'd like to talk about this because I think this kind of exemplifies, if you like, that combination of lived experience through this enormous family that in Scandinavia with periodic paralysis. This is in the pre-genetic era, so in all likelihood they had a combination or probably hypokalemic periodic paralysis. And then these researchers, so Tara Links was the first author on many of these, and then Machiel Schwartz and Hans Oosterhuis were involved in many of them as well. And I think, the reason I think this was so important is because historically in many of these studies, especially before the gene was identified, is in order to define who is affected, as the name would suggest, it was those who had attacks of paralysis. But what these researchers did that was so different was that they came up with a technique. So as well as going and examining family members, so I think they met essentially all of the living members of that family, traveling over the countries in Scandinavia to visit them and examine them. They also devised a test of neurophysiology. So I'm a clinical neurophysiologist, like I do electrodiagnostics, seeing patients. And they came up with a way of testing the patients they saw with this technique. And so what this is, you can see this person's arm here, so they're measuring force. But what they also have is these 3 sticker electrodes on the skin over the biceps. And by looking at the electrical activity in people's muscles on the surface, and then doing some very fancy statistical analysis and computer programming, they could distinguish the people who had periodic paralysis from those that couldn't. They also, by looking at the speed at which the signals traveled across the muscle fibers, it gave some information on the ion channels within the muscle fibers. And so from that, they were able to distinguish the group here of healthy volunteers and asymptomatic relatives from the group in red here, which were the people who'd had attacks of paralysis. But critically, they also had these 4 participants here, the yellow stars, which were clearly separated from all the controls and asymptomatics. But then these were relatives that were considered asymptomatic, but they seemed to cluster with the patients. On the basis of this, 2 of these people agreed to undergo muscle biopsy. Both of them had the vacuoles that characterize the myopathy, the fixed weakness that can occur in periodic paralysis. And the other 2 later went on to develop attacks of weakness that characterize the condition. So I think the really important thing here is that they were able to develop a test or a biomarker that helped to distinguish people before the gene was defined, and not just relying on people having attacks of paralysis. So that's just highlighting those ones there. And yeah, as I say, they went on to have the biopsy and showed the classic features of the vacuolar myopathy. So they carried on then using this technique and went on to really be the first people, I think, to try and look at the phenomenon of permanent muscle weakness. And I think the reason they were able to do it is because they also had this test aside from attacks of weakness to identify people. So within these patients, this is a summary of one of their studies, and I just wanted to point out some things from it to you. So there were 64 people that they had identified. 38 of them had had clear attacks of periodic paralysis, and so they were confirmed as affected. But 26 of these had not had any attacks. So of those, 5 of them had had a muscle biopsy, which showed the clear features so that they knew that they were affected. 21 of them hadn't had a biopsy. So they were able to use these surface EMG, the stickers on the muscle looking at the electrical activity, to identify those people who were still affected, and then confirming it in that their children went on to have attacks. In those that didn't have the surface weakness, they identified people who had the permanent muscle weakness there with the PMW, and then confirmed the passing the gene on by their children having attacks or having these abnormalities on the electrical tests. So it's just highlighting that there. And I think the kind of really important aspect that they were able to do because of this work is to show that actually the people that they were able to identify as affected but who didn't have attacks of weakness did have signs of permanent muscle weakness. And the extent of that permanent muscle weakness here shown as PMW increased with age in both groups. So even those who had never had an attack of paralysis were describing and were, when examined, had evidence of this permanent muscle weakness. And the interesting thing, this is just an extract from that paper, that they described that both of the groups, whether or not they'd had the attacks of paralysis, described their permanent weakness in a similar way. And I don't know if this description will resonate with people in the audience, but they noticed weakness of their knees, pain and stiffness of their upper legs and backs. And the other key thing is that they said these complaints sometimes fluctuated. So although it was a fixed degree of weakness, the extent of that weakness did vary, but was present almost continuously. And so what they then showed is looking at, so in this case they were looking at the weakness by measuring strength, so this is shown in newtons, and looking at the quadriceps, which we believe is one of the muscle groups most affected. And on the left, you can see the people with periodic paralysis as defined by the previous slide. So not some of these people will never have had clear attacks of paralysis. And you can see on the bottom here, they're divided according to their age. So from 10 to 80. And then on the vertical axis here, it's according to the strength in the quadriceps. And this kind of cutoff is showing 160 newtons, so where you see a big functional difference in your strength. And what you can see is in the younger age groups, the strength is relatively well maintained, but once they're going above 50, then all of the participants that they met had quite significant levels of weakness. And this was in contrast to their asymptomatic relatives, where even at the older ages, that they were able to maintain their strength pretty well. So I think they were able to clearly demonstrate the presence of this phenomenon in periodic paralysis, but they also showed that it's not limited to those that have the attacks of weakness. And this work, so that was done late 80s and early 90s. And then there has been quite a gap, really, I think, in trying to look at this again and drive that forward. And I think that a lot of that's been a focus, really, in trying to understand the mechanisms of the disease and how the episodes of paralysis manifest. And Dr. Cannon has obviously been a key driver in taking that understanding forward. But recently, there have been some studies now looking at MRI, so magnetic resonance imaging, in periodic paralysis. And this is really an important step because it gives the opportunity to be able to look at the muscles and potentially detect changes before people are aware of them clinically. So this was one of the earlier studies. So this is looking in patients with hyperkalemic periodic paralysis due to mutations in the sodium channel. And this is an image of a whole body MRI. So in the middle, you can see the organs, and then you can see some of the muscles here in the legs. The lines represent where we call them slices, so the kind of cross sections of the muscle imaging have been taken. On the left, this is an image from a 49-year-old with hyperkalemic periodic paralysis, and on the right, or on my right anyway, a 14-year-old with hyperkalemic periodic paralysis. And on the top here, you've got an image as if slicing through the forearm, looking at the muscles there. The next image on both sides is looking at the thigh, and on the bottom, your lower leg. And so what hopefully you can appreciate for both the 49-year-old and the 14-year-old, when you look at the forearm, the muscles are dark. There's these bright white bits here, which are bone, but otherwise it looks nice and dark. So this looks like healthy muscle. When you go down to the thigh in the 49-year-old, you can potentially appreciate, so this white bit here is the femur. This is the front of the thigh, so where the quads are, and this is the back of the thigh where your hamstrings are. And you might be able to see that there's some extra white at the front, and that represents some fat within the muscle, which happens can happen as the disease progresses and is associated with weakness. You can see on this side that there's a difference in the muscles that are affected. So the anterior muscles of the thigh have more of that whiteness in them than the posterior muscles. But if you compare this image from the 49-year-old with the 14-year-old, hopefully you can see that there's quite a striking difference in the amount there. So on this side, it looks healthy. You see the muscle as dark with relatively little, if any, of the fat, the bright white infiltrates there. And then this is looking at the calf, and you can see there it's more towards the back, so in the gastrocnemius muscles, where you see this brightness occur. And again, there's a big contrast between the 49 and the 14-year-old. This group also did a study where they compared the same members of a family over a 3-year or 4-year duration, and they were able to show a change in the appearance of the muscles within that time point. This is a more recent study done, which I contributed to from the group in London, and it was led by Vino Vivekanandam. It's Mike Hanna's group. And again, looking at muscles in the leg, so a section of the thigh and of the calf. But here it was looking at the clinical cohort. So the way that it's set up in the UK with the National Health Service, we have a national referral centre. We have a highly specialised service for skeletal muscle channelopathy patients. And the benefit of that is that there's a sort of a fortnightly skeletal muscle channelopathy clinic, and the majority of patients in the UK can be seen at or by that clinic. And it enables that, I guess, that working together and that collaboration between those with the lived experience and those with the learned expertise to really drive forward knowledge and understanding. So this was based on MRIs done within those patients as part of their clinical care. And as a result, they were able to, or we were able to look at different patterns between the different types of periodic paralysis. So here initially you can see sodium channel periodic paralysis, and hopefully you can appreciate it looks a similar pattern to the last slide I showed, in that the muscles at the front of the thigh there perhaps show more whiteness than the muscles at the back. And the muscles at the back of the calf there, the gastrocnemius, are the ones that you see as more white. This middle panel here is from people with Anderson-Towle syndrome. Now, in the thighs, relative to both sodium channel and calcium channel, there was a lot less muscle fat replacement that was seen. But what was found is that sometimes they can have more proximal, so sort of higher up in the pelvis, some fat replacement there, which links to the extent of weakness. And then on the right, you can see the calcium channel hypo-PP. And if you compare the two images from A to C, at least in this cohort, it looks like it may be different muscles that are affected initially as the weakness progresses. Why is that important to know? I guess it might help us in understanding how and why this is happening and what is driving it, trying to understand which muscles are affected. It may also help target in the future the type of physio, the exercises that we can do to look at that, and may also be useful as part of the diagnosis. The more we can understand in these patterns, the better that we are at picking them up. The other group that has been doing major studies looking at MRI is John Bissing's group. And they have done a study where they looked again at interval MRI. And the really important thing that they have shown is that whilst the MRI data between the baseline visit, which is shown in blue, and the follow-up visit, which is shown in black, did change. So here you've got on the left asymptomatic carriers, in the middle periodic paralysis patients, and on the right patients with both weakness and permanent weakness. There was a difference in the MRI scores and what they call the muscle fat fraction, so the amount of white within the muscle picture between baseline and follow-up. There wasn't a difference in the strength. And that's something that's a really important thing to be able to detect, because it lays the foundation, if you like, for being able to develop and hopefully deliver therapies in the future. You need to be able to detect it to determine if the treatments will work. So since the initial work by Tara Links and sort of looking into the phenomenon of the permanent weakness in periodic paralysis, there has now been more focused work looking at MRI, trying to understand the pattern on which muscles are involved, trying to determine whether we can detect really small changes, whether it will be a sensitive biomarker, and trying to look at how it's affected. And I think the other thing to flag, certainly in this study, is that there was evidence of MRI fat replacement in muscles earlier on than had been anticipated, and in patients who didn't yet exhibit the weakness. So it's definitely there. In order to take these observations forward and try and understand mechanisms and hopefully ultimately improve treatment and management of them, what we tend to do is then try and look in the mouse models, and these have been a key factor in understanding the episodic weakness and the mechanisms behind that. So as part of my PhD, when I was working in London, and actually really born out of conversations that I had in that clinic, where I remember speaking to patients, and I remember quite vividly there were several patients and in a row from different clinics that their episodic weakness was under control, but the thing that they told me they were really worried about actually was this permanent weakness, and that was what they were very concerned about also for their children. And partly based on that conversation, I wanted to try and look into the mechanisms of it. And so I used a mouse model, which is called the dragon mouse model. So it's quite an unusual mouse model because it's an unusual mutation, and the mutation was found in the mice, if you like, by chance. And then it was characterized, and it was found that it was in the sodium channel, and then it was found that there was a patient who had the similar mutation with a hyperkalemic phenotype. And in the original paper, which was in 2014 by Corriciano et al., they showed that these mice had similar grip strength. So here on the vertical axis, you can see the grip force of these mice. And then on the horizontal axis, you can see their age in weeks. And from about 60, 70 weeks in a mouse is about middle age in a human. So from about the age of 40. And they found in both males and females that from around middle age, they started to show a deficit in force compared to their healthy litter mates. So their healthy siblings who didn't have the sodium channel mutation are shown here in black, and the animals with the periodic paralysis gene, the sodium channel gene, are shown in red. And so it recapitulates really what people have described, that from around middle age, from around the age of 40, there starts to be a decline in force. So this permanent weakness starts to appear. And what's interesting with these mice is that they do have these episodes of hind limb immobility as well, and they have myotonia. But whilst all of the females have myotonia, only about 50% of the females will exhibit these immobility, hind limb immobility, which kind of also mirrors what's at least reported in terms of the sex difference of some of the episodic attacks. But you'll notice that the females here do also show this progressive weakness in their grip strength. So I wanted to look and see, they've shown that they've got this progressive weakness. Do they also have a reduction in the episodes of attack, as has been described? So there's been several papers over the years when talking about people with periodic paralysis, suggesting that as people get older, they have fewer and less severe attacks or episodes of muscle weakness, but they start to develop permanent progressive weakness. And so this is showing, so they're called dragon mice. If you just focus on the different colors in the graph here, on this vertical axis, this is the force of these, the mouse muscle. And at the beginning here where it's 1, that's its force in normal potassium. And then during the red bar here, it's exposed to really high potassium. And then during this green bar here, it's like a recovery solution. So it's trying to recover force. And these are the mice with the periodic paralysis mutation. The gray ones here are young, so young adults, so that's up to 13 to 26 weeks. The middle-aged ones are 70 to 90 weeks, so around that time where you saw the difference in grip strength start to appear. And then the old ones here were 104 weeks. And what hopefully you can see is by the time they're getting to 104 weeks, they're more resistant to the high potassium. They do show a drop in their force, but it's nowhere near as much as the middle-aged or old. But what's even more striking is you see a similar effect in the WT stands for wild type, so they're healthy siblings. So here in black are the young. So here is their normal potassium. Then in high potassium, they lose some force, not as much as those with the periodic paralysis mutation, but some. The middle-aged ones lose a similar amount to the young adult, but the old ones manage to maintain their force in the high potassium. So it suggests that at least some of this effect, this change from the kind of episodic weakness to maybe the permanent weakness, at least some of it may be linked with a normal, in inverted commas, but normal aging process. And so just showing that here, really, thinking about, so I had the good fortune, we have a very long stage of junior, well, it's called junior doctor, but postgraduate medical training in the UK. So you have to go around to various different hospitals and work in different specialties. And before I started my PhD, I was working with Professor Avan Sayer in Southampton. And she is a geriatrician who's interested in what she calls the life course approach and very interested in skeletal muscle and how it changes with age, its function changes with age. And so when I started meeting and working with people with periodic paralysis, I was really struck by some of the overlaps in terms of the timing of things. So for periodic paralysis, you'll have this varying length of a pre-symptomatic stage. So depending on the underlying gene mutation and varying within families. And then, as you will know, most people will have these dramatic episodes of weakness. And according to the literature, at least, and from many of the case reports and from questionnaires, quite often those will start to reduce in their frequency and severity as people approach middle age. But what people will then often start to report is that they feel their strength also declines. And that's at a faster rate than their unaffected relatives. And this graph, or this trajectory, if you like, has quite an overlap with the trajectories of healthy muscle mass. So in the absence of disease, if you look at those graphs measuring that, you'll see that it sort of peaks in mid-20s. It's then stable till around 40 when it starts to decline. That effect is even more marked when you look at grip strength, and it's even more marked if you look at things like world record times for running 5 kilometers, the world record for amateur marathon finishing times. Then they tend to stay about stable until 40, and then sadly they start to decline. Here's the marathon finishing time. So here I've put on the same graph. So on the bottom there is age going up to 100. And this is, the y-axis is sort of different scales for different graphs here, but it's a representation compared to the maximum proportion of peak. So you can see here showing marathon finishing times, it reduces, probably the lowest in mid-30s, and then gradually increases and then much more rapid increase towards 80. But what's interesting is if you look, the energy cost of running also seems to follow that course in that it's relatively low, but after the age of 40 seems to increase significantly. And here, something called the number of COX negative fibers. So this is something that you can look for on someone's muscle biopsy. COX negative fibers refer to things called mitochondria. Mitochondria are like the batteries of the cell. They provide the energy that the cell needs to function. And a lot of the energy within muscle is used to move ions around, sodium, potassium, calcium. And so you can imagine that if maybe you have an ion channel mutation, the amount of ions you're having to move around might be increased, and that might increase the stress on this system so that you may be seeing things at an earlier stage. And I guess just to go back here, so you can see it's showing up okay. So this is data from the MRI study that I showed you previously, the one from London. And here on the vertical axis, it's showing you the extent of changes. There's something called a Mercury score, which basically is a marker of how severe the MRI changes are. And on the x-axis here, you can see people with different ages, and then they're organized according to whether they have a sodium channel mutation, a potassium channel mutation, or a calcium channel mutation in blue. But what hopefully you can see that as people go up and past sort of 40 up to 50, 60, 70, the extent of those changes on the MRI increases significantly. So I think then probably the question in most people's minds is what can we do? So you've shown me these things, but what can I do? And I think at the moment, what we can say is just thinking of the general approach. So it has a clear link with aging. So a general approach, healthy aging, the clean living, avoiding the triggers of your attacks as much as you can. And then although I appreciate it's extremely difficult managing this around triggering an attack and not triggering attack, but trying to maintain or build up as much physical activity as you can, but really key things saying that you build it up gradually, and whenever you're doing things, really important to gently warm up and gently warm down so that you sort of very slowly build up what you're doing, and definitely avoid going from not doing much to trying to do a lot suddenly, because I think that's where you can also create real problems. But doing what you can and slowly increasing it is one of the key things to recommend, and then sort of general approaches, as you would for anyone in the population, should increase the background muscle health. What about for periodic paralysis specifically? So I think that's much more tricky. I think it's an area that we need to work on, and we are working on, and working together will hopefully deliver the results. I think it's critical to understand the natural history of the condition, so what you might expect and when. It's really, really important to have what we call biomarkers. So that's why I think these studies with the MRI are so important. Why is it so important to have biomarkers? Well, if you want to show that a drug works, ideally, especially in a rare disease, you want to be able to do it as quickly as possible, and with as few people as possible. And in order to do that, you need to have something that can detect really small changes. You also want something to detect really small changes, because the ideal situation is you want to be able to treat it before you have changes that you feel clinically that prevent you from doing things. Ideally, we can detect a few, some percentage change in fat on MRI, which you may never be aware of, and ultimately try and treat at that point. So that's a really good step forward to start to develop those biomarkers and expand them. But then you need things to treat, and I think Dr. Cannon is speaking, and there are other, he and the researchers within this field, I think, are driving forward understanding and then testing new therapeutics, and ensuring that what we call preclinical pipelines, so that there are tests and therapies coming through, is critical. And then having in place, because it is such a rare condition, in order to prove that something does work and to do things properly, because there are very few treatments that aren't without risk. So if you're going to take something, you want to know that the risks outweigh the benefits outweigh the risks. And there we need international collaboration in clinical trials. And I think periodic paralysis and channelopathies is one of the good examples of that. There have been randomized controlled trials done. It's one of the few rare diseases where that's happened. And so that's really positive and something to take forward. And then I think finally, if you feel able, and depending on how you feel able, to get involved in research. And that doesn't always mean going and attending a study. I think communicating people's lived expertise, highlighting perhaps symptoms or signs that have been overlooked but that you're aware of, and then can point research accordingly. Contributing where possible to the natural history studies, so that's understanding the disease. That can be in person or with questionnaires, and then the biomarkers, and ultimately, we hope, clinical trials. And I think I have to thank ChatGPT, I must admit, for the diagram of the lived experience and learned expertise. When I first tried to generate it, they had like a little footprint here instead of the pathway. So I've refined it. But I think that's a cornerstone, and really reflects how things have progressed, and hope how they will continue to progress. So hopefully I'm not too much over time, but just to say thank you to all of you, and thank you so much for inviting me to talk to you today. It's a real honor.
Thank you, Dr. Suetterlin. We do have some questions from our audience, if you're willing to answer a few of them. I think you really did spend a lot of time in the last couple of slides answering the most upvoted one, which are specific techniques or remedies that help prevent or slow down progression of muscle weakness. So if there's anything else you'd like to add, that's an option. But the next question is, I've lost muscle strength in my quads and calves. What worries me is the daily pain I have. Are there suggestions to lessen pain?
Yeah, so thank you very much. I think it's a really important question. And I think pain in muscle disease is something that we generally understand poorly. So I had a colleague in London, Dr. Emma Matthews, who had an interest in this and looking into it. So I think they're the general measures, which I'm sure that you're doing already. I think that people seem to respond quite differently to different medications. So depending on what your underlying condition is, sometimes if there's myotonia, treating that may help, but I think it doesn't take it all away. Lessening attacks may help, but I think sometimes the other thing that's underestimated is the contribution of a secondary, if you like, musculoskeletal pain to this. So as your muscles get weaker, it can then put extra pressures on your joints, and that kind of contribution can exacerbate it. So I think at the moment, the best advice is this sort of general approach, which I appreciate isn't entirely satisfactory. But I hope that as we go forward and can understand things better, in the future there may be more targeted approaches as well that we can offer.
Thank you for that. I have one more question from remote, and then I'll bring it to one here. I believe I have permanent muscle weakness in my quads because I have had so many episodes now that I am in my late 60s. I have weakness now in my quads, and even though I exercise with land and aquatic exercise, I cannot get stronger. Do you have any advice?
So I think you're doing the right thing, and to carry on doing the exercise, because even if you don't feel that it's improving the strength in your quads, it will be improving your overall health, and that will ultimately improve things for your muscles as well, because they work within that system. I think it's difficult. We don't know in terms of once there is fat there, whether that is something that it's possible to reverse or not. So I think it's working with what you have and continuing to gently do what you can do, and also allowing on the other muscle groups to maintain the strength that you have there.
Thank you. You mentioned getting involved in research. How would we go about doing that?
So within the UK, a lot of people are linked up with our National Channelopathy Service. We also register clinical trials as a website, clinicaltrials.gov. I think that the Periodic Paralysis Association is probably, and Sienna and others will correct me if I misspeak, but I think probably a great place to start, because trials and future research should be advertised there. And because it is such a rare condition, I think most researchers will reach out to try and advertise it and highlight it so that as many people as possible who would like to can get involved.
I'm going to try to combine two similar. How do we get our doctors to test for permanent muscle weakness? And then there's a more specific one that talks about muscle ultrasounds and myopathies. Could muscle ultrasounds be an effective way to detect and track the progression of fatty replacement in the skeletal muscles?
So if I go to the second one first, so I'm a massive fan of muscle ultrasound. I think it's an excellent technique. It can detect the changes sort of on muscle ultrasound. There is work being done to try and improve it as a way of tracking. I think the difficult thing, so when you do an ultrasound, the muscle tends to get brighter, and it is, when it's very severe, it's easy to see by eye. When it's normal, it's easy to see by eye, but in the middle, sometimes it's difficult. But because there are a lot of parameters on the ultrasound machine that can be changed, and that affects the brightness, if you like, of the image, it is remarkably difficult actually to extract a numerical measure so that you could compare your muscle brightness between visits. So it is something that there are research groups doing, but those research groups then have got their own kind of database, if you like, to compare it to, which many practitioners won't have. So at the moment, I think MRI is probably a better measure in terms of the looking at progression over time. That's not to say that that will stay that way, because I think there's a lot of work being done to bring that ultrasound possibility to many more practitioners. So I would say watch that space. I think it's an excellent tool, and with people with the expertise, then it can be used. Can you remind me of the other question? Sorry, the first one.
Yes, although it's been taken down. I think it's generally, do you have any suggestions in terms of getting a doctor to actually run these tests?
Yeah, I think, well, I would hope that people will examine it. So if you've got sort of fixed weakness that's affecting what you're doing, then they can clinically examine you, so testing muscle strength. But as I've shown, the changes may precede that. The availability, I think, of the MRI and ultrasound varies in different places. So it may be that you're able to have that kind of test to do it. EMG, so electrodiagnostics, when people start to develop the fixed weakness, that may also detect changes on the muscle to show that the muscle is developing what we call a myopathy, so not working. So those, I think, if you're looking at other tests, those would be the most helpful to do. The difficult things, I think, we need to get some more specific therapies to guide treatment, because at the moment there isn't any specific one. The hope is, as therapies come that might target the underlying problem in the gene mutation, then that may also effectively prevent this weakness. But that's something that I guess remains to be seen. So we're at the early stages, really, I think, of trying to develop that.
So my question has to do with PEMF therapy, which is the electromagnetic waves to stimulate cellular repair, reduce inflammation, and to also get rid of pain. Is there any studies being done to show if that either slows the progression or possibly could even help with the pain associated with the weaknessing that happens in the muscle?
I'm not aware of any. It's not a technique that I'm very familiar with, so I'm not aware of any. But I'd be very interested if you have experience with that and if you feel that that's helped your symptoms. But no, I'm afraid I'm not aware of any in that area.
My daughter is she does those therapies, and it helps her Parkinson's patients with the pain. So I would assume maybe it would help us, just maybe because Parkinson's pain, I don't know if it's similar to the pain that we suffer from, but there is a great difference in the pain before and after treatment, and it lasts for a few days. Okay,
that's interesting to know. I'll have a look into it and see. I think the mechanisms of pain are I think, difficult and poorly understood, and definitely an area that we need to try to move forward. So it's an interesting point. Thank you.
Okay, this is going to be an unpopular stop, but we are at time. And so, Dr. Suetterlin, thank you so much for coming in. We really appreciate your help, and we look forward to more sessions later as we develop this relationship. Thank you.
Thank you very much.